Hello, my name is Tin Lee, and I'm a third year medical student at Case Western. I'll be presenting our study, Healthcare Utilization After Buprenorphine Prescription in a Community Emergency Department, a retrospective cohort study. I would like to thank my mentor, Dr. James Neuenschwander, for this opportunity, and I would like to thank Drs. Frank Peacock and Brian Heaston for assisting with study design, statistics, and abstract drafting. I have no disclosures. As we all know, the opioid epidemic is one of the major public health crises in the US. From February 2018 to February 2019, 69,209 people died in the US from opioid overdose. Preliminary research has also shown that disruptions in addiction services caused by the COVID-19 pandemic could further worsen outcomes for these patients. We also know that medication-assisted treatment, or MAT, with drugs such as buprenorphine is effective for treating opioid use disorder, or OUD. We also know that the emergency department, or ED, is a key point of contact with the healthcare system for OUD patients. Lastly, recent studies from urban academic centers have shown that emergency physician-initiated buprenorphine improves outcomes for OUD patients. These studies largely focus on MAT adherence at 1 or 6 months as their outcome of interest. In this study, we investigated whether emergency physician-initiated buprenorphine in a rural community setting decreases subsequent healthcare system utilization for OUD patients. Our setting was a community hospital in southeastern Ohio with an average annual ED census of 71,354 visits per year. We performed a retrospective matched cohort study. We began by reviewing the charts of all patients prescribed buprenorphine in the ED between January 2018 and mid-May 2019. We abstracted demographics and opioid-related ICD-10 codes for these patients. We then created a case-matched control cohort for our experimental group. We used the electronic medical record to create a list of all patients who presented to the site ED in a similar time frame and received at least one of the opioid-related ICD-10 codes received by the experimental group without receiving buprenorphine. Once we had that group, we selected a single case-matched control for each member of the experimental cohort on the basis of age, race, and sex. Outcomes between these two groups were compared at 12 months. Our outcomes of interest were 12-month ED visit rate and 12-month all-cause hospitalization rate, both of which we consider measures of healthcare system use. We also recorded 12-month opioid overdose rates as a measure of safety. In terms of statistics, differences in event occurrences between the two groups were assessed with Poisson regression. Here we have the demographics of the experimental and control cohorts, as well as that of the combined cohort. As you can see, both groups are well matched in all of these demographic parameters, with an average age of 33.4 years, as well as both groups being roughly 90% Caucasian and roughly 60% male. Here are the outcomes data. We calculated the average rates of hospitalizations, ED visits, and opioid overdoses in both groups, and then compared those rates using incidence rate ratios, or IRR values. These values show whether or not one group experienced a significantly different rate of a given event compared to another. For example, if two groups experience an IRR of 1 for a given event, those rates would be identical. As you can see, the experimental group experienced significantly lower 12-month rates of hospitalizations and ED visits compared to controls. We know this because both IRR values are less than 1, 0.34 for hospitalizations and 0.61 for ED visits, and both have 95% confidence intervals that do not include 1. In contrast, the two groups experienced very similar rates of opioid overdoses, with an IRR of 1.04 and a 95% confidence interval that does include 1. In conclusion, compared to matched controls, patients who were prescribed buprenorphine by emergency providers experienced significantly lower 12-month ED visit rates, significantly lower 12-month hospitalization rates, and comparable 12-month opioid overdose rates. This small sample size, retrospective, single-center study shows the promise of emergency provider-initiated buprenorphine prescription to safely decrease healthcare system utilization in OUD patients. Here are our references. Thank you very much.
Thank you for coming to our presentation on the acute toxicity associated with cannabis use, smoking versus snacking. Our study was performed in Michigan, which in late 2018 legalized cannabis. So there's been an increase of cannabis availability to adults. This includes consumed or edible forms of THC, which have a clinically different effect than smoked THC. So the purpose of our study was then to compare the clinical effects of smoked versus ingested cannabis products. This study was a retrospective cohort analysis of consecutive patients enrolled over a 24-month period from November of 2018 after the legalization of cannabis in Michigan through October 2020. These patients were all seen at 7 different emergency departments, including 3 rural medical centers, 3 university-affiliated hospitals, and then a children's hospital. And then you can see what we collected below in terms of data, and that included demographics, pre-hospital care, product ingested, co-ingestants, clinical findings, and then finally hospital outcomes. During the 24-month period, we saw 1,039 patients that were evaluated for THC toxicity, and of those, 17% were attributable to edible cannabis. The frequency of both inhaled and edible cannabis presentations increased throughout the study period. And then the age of patients that we saw in terms of ingested cannabis was 30.7 years old on average, compared to a slightly younger age of inhaled cannabis of 27.8 years old. With the ingested cannabis group, we also saw a wider range of ages of patients that presented to the emergency department, going from 1-year-old to 84 years old. And you can see again down below that in the ingested group, 10% of the patients were over 64 years old and 6% were children younger than 12 years old. This chart shows what the nearly 17% of patients who were ingesting cannabis ingested. The most common was baked goods, including brownies and cookies. That was closely followed by candies and gum, and this includes gummy bears. And then less frequently, we saw beverages, raw marijuana, honey, capsules containing just THC, and then cannabis resin. Patients who present to the emergency department acutely intoxicated on cannabinoids or with cannabinoid hyperemesis syndrome more frequently presented after inhaled cannabis when compared to edible cannabis. In contrast, the patients that had edible cannabis presented more frequently with psychiatric, cardiovascular, or neurologic complaints. Interrelated reliability, looking back on these patients' charts to determine if their symptoms were from THC, was excellent, with a Kappa statistic of 88%. In our study, ED visits attributable to cannabinoid toxicity increased since the legalization of marijuana. 17% of the visits in this study were due to edible cannabis, which had a different demographic profile and a different clinical presentation compared to patients that presented after inhaled cannabis use. Given the increased frequency of cannabinoid overdose and accidental exposure, it seems that we need additional regulation of edibles. This regulation may come in the standardization of product formulations, better quality control measures, child-resistant packaging, and appropriate warning labels.
Good day, my name is Mike Durock, and it's my pleasure to be presenting our research entitled Pediatric Diphenhydramine Ingestions Reported to the National Poison Database System 2007 to 2020. My co-author Stephen Thornton and I have no financial disclosures. Diphenhydramine is a near ubiquitous medication in the U.S. pharmacopoeia that's been available since 1946 and over-the-counter since 1985. It has a very complex pharmacology, including its most typical use as an antihistamine, but it has the potential for serious adverse effects when taken in overdose. Overdoses are well described in the medical literature and are associated with seizures, cardiac dysrhythmias, and death. As a result of this serious toxicity and the presence of newer, safer, and some might argue better medications, some sources argue that diphenhydramine should not be available over the counter. There's also concern for potential abuse, especially amongst adolescents, given a relative ease of access. In September of 2020, the U.S. Food and Drug Administration released an advisory describing serious heart problems, seizures, coma, and death when taken for intentional abuse or misuse purposes in response to social media challenges describing high doses for hallucinatory experiences. My co-author and I sought to characterize the reason for oral exposures to diphenhydramine amongst pediatric patients, the frequency of adverse effects, medical outcomes associated with oral exposures, and trends over time. The NPDS defines pediatric as less than or equal to 19 years of age. The NPDS is also the data warehouse for the U.S. Poison Control Center system, and data is uploaded approximately every 9 minutes. It represents the largest repository of information regarding U.S. poisoning, exposures, and management thereof. We queried the database for cases in which diphenhydramine was the only product of exposure between January 1st, 2007 and December 31st of 2020. In addition to defining pediatric in accordance with NPDS, we performed age subgroup analysis also in accordance with NPDS. Outcomes are defined according to the NPDS as described in this slide. 408,706 total exposures were reported. The overwhelming majority of these were due to oral ingestion exposures. 293,450 pediatric ingestions were reported, with the majority of these amongst the very young. This slide represents the trend in the total number of exposures reported by year. Both the overall number of pediatric ingestions and the number of ingestions amongst those less than or equal to 5 years of age has been falling in recent years, while the number of cases amongst adolescents 13 to 19 years of age has been increasing. This slide represents the percentage of total cases by year due to an intentional reason, such as abuse, misuse, or suspected suicide. All intentional cases have been increasing in terms of the percentage by year, as has suspected suicide, while abuse, misuse, and unknown has remained static. This slide represents the number of cases due to intentional reasons in those less than or equal to 5 years of age, and I will draw your attention to the y-axis. This represents a very, very small percentage of total cases amongst the very young. Amongst 6 to 12-year-olds, you'll see that both the number or the percentage of cases by year due to an intentional reason and the percentage due to suspected suicide has been increasing, while abuse, misuse, and unknown remains static. This pattern is also observed amongst 13 to 19-year-olds. The percent of cases that experienced a more serious outcome, such as moderate, major, or death, has similarly been increasing amongst cases overall, as well as amongst 6 to 12-year-olds and 13 to 19-year-olds. In this case series, there were 36 deaths overall, representing 0.01% of the total ingestions reported to the NPDS, and the majority of these were amongst 13 to 19-year-olds. Of deaths reported, 25 were due to an intentional reason, and the majority of these were due to suspected suicide. Only one death was reported due to a misuse or abuse of diphenhydramine. This slide represents adverse clinical effects, specifically the ones listed by the FDA in their advisory, and you will see that a significantly higher frequency of seizures, cardiac complications, or coma was reported amongst suspected suicide over misuse or abuse. We demonstrated an increasing frequency of suspected suicide as the cause of pediatric diphenhydramine exposures, while the frequency of misuse and abuse has remained static in all age groups. There's also an increasing frequency of more serious outcomes. Deaths occurred infrequently in the current case series following oral ingestions, but the majority of these deaths were due to suspected suicide. Cardiac complications, seizures, and coma also occur infrequently, but much more in suspected suicide over misuse and abuse as reasons for exposure. Thank you.
Good afternoon. My name is Brandon Berger. On behalf of my collaborators, I am pleased to present our work on the epidemiology of cannabidiol-related cases in the National Poison Data System during 2019 to 2020. We appreciate the moderators for the opportunity to share this work. We have no related competing interests or funding to declare. Cannabidiol, better known by its acronym CBD, is a non-psychoactive cannabinoid compound derived from cannabis sativa plants that has become a popular supplement in a wide variety of products marketed with a wide variety of advertised benefits. A 2019 Gallup poll indicated that 14% of adult Americans had used CBD-containing products. while a purified CBD preparation is FDA approved for rare congenital epileptic disorders, other preparations of CBD, which vary from tinctures to sodas to gummies to eye creams, are subject to very little regulation. And marketing has outpaced science in terms of identifying therapeutic benefit. Highly variable CBD content and the presence of other non-advertised compounds has been demonstrated in previous analyses of commercially available products. The popularity of these products was boosted in recent years by the 2018 Federal Agriculture Improvement Act, which permits the cultivation of cannabis with low content of THC, the psychoactive component of the plant. This has normalized the status of cultivation of CBD-rich cannabis strains in the United States. And this has contributed to the rapid growth of the CBD industry, which has grown 10x in the past 7 years. The American Association of Poison Control Centers is the unifying organization of the nation's 55 poison control centers. And they maintain the National Poison Data System, a data warehouse into which each poison control center submits de-identified case data after a poison information professional provides necessary poison exposure management and information services to callers, and records case details. Substances are identified by a unique code, and in 2019, a specific code for CBD was introduced for the first time. We performed a descriptive analysis of the first year of the use of this new code to understand trends in CBD cases reported to the poison control centers. We found that cannabidiol was reported as an exposure in 1,368 cases. And the variety of formulation reflects the breadth of product availability, with liquids, solids, and creams as the most common substance types. Exposure reasons showed a preponderance of unintentional or erroneous exposures, as well as adverse reactions. Small contributions in cases came from substance abuse or suspected suicide attempts. Finally, while most exposures were classified as having no or minimal effect, 9% were classified as having a moderate effect, and 1% were classified as having a major effect. No deaths were noted among CBD-related cases. We noted that there was a statistically significant increasing trend in cases by month for the year investigated. And as we look at an age breakdown of cases reported to the NPDS, it is notable that over 35% of exposures occurred in children 5 or under, and approximately half were in children 18 or younger. These statistics closely mimic the general age distribution of cases handled by the poison control centers. Cases from all states, with the exception of South Dakota, as well as cases from Puerto Rico and U.S. territories were handled. However, there was considerable variability in the per capita rate of cases for each state. Reported symptoms are logged in the NPDS with each case, and we performed an analysis of the approximately 1,200 cases in which CBD was the only identified substance to better understand medical effects of products labeled as containing CBD. This graph shows the 20 most frequently reported symptoms in the gray box, with breakdowns for pediatric patients and for adolescent or adult patients. Notably, CNS depression, tachycardia, dizziness, vomiting, and agitation were the most frequently reported symptoms overall. While symptoms were overall less frequently reported among the pediatric age group, CNS depression was by far the most notable symptom reported within that group, while older patients were noted to have a more varied gamut of symptoms. At this point, I would like to leave you with a few final thoughts on this descriptive analysis. First, CBD-related cases are increasingly reported to the NPDS, a reflection of the substance's growing popularity. Second, cases in pediatric patients make up 50% of total reported exposures, and this may be a group of interest for future study. Third, symptoms reported in these cases were variable, including CNS, cardiac, and GI symptoms. However, among symptomatic kids, CNS depression was the most common finding. Finally, this study takes a pragmatic, descriptive approach to exposure to products labeled as containing CBD, and should be considered in that light. The exact role of CBD or any other substance or adulterant can't be identified via database review. Thank you for your time. and I would be happy to take any questions.
Hi there, I'm Professor Drew Richardson from Canberra, Australia, and this is my lightning oral on the prevalence of alcohol-related ED presentations in Australasia 2017 to 2020. I'd like to thank my co-authors and to thank the Australasian College for Emergency Medicine for funding this study, and to note that there are no conflicts of interest to declare. Over the past 8 years, my unit has established a point prevalence snapshot methodology of surveying emergency departments on the number of alcohol-related presentations. This is conducted by fax and telephone and is funded by the Australasian College for Emergency Medicine. This paper aims to describe the changes in prevalence of alcohol-related presentations in Australasian EDs at 0200 hours on the Saturday before Christmas over the 4 years 2017 to 2020. It is a study of responses from all adult and mixed adult pediatric EDs answering the last 4 surveys. We already know that there's a very low incidence of alcohol-related presentations in pure pediatric hospitals just before Christmas. The study was analysed by jurisdiction, obviously prospectively defined, and in 2020 a subgroup analysis was performed looking at Australian states with recent COVID-19 related restrictions. It should be noted that the incidence of COVID-19 in Australasia was extremely low, but when cases did occur, there were quite severe local restrictions until the outbreak was controlled. At the time of the survey, restrictions were in place or had just been in place in 3 Australian states. 83 of 152 possible hospitals answered all 4 surveys. That's 55%, which is pretty good for this sort of work. And the bottom line was that alcohol-related cases fell from 13.1% of those in ED in 2017 to 11.1% in 2020. However, it wasn't that simple on the jurisdictional analysis. There'd been no significant change in the New Zealand hospitals, in fact a slight non-significant rise in the percentage of alcohol-related presentations, possibly due to small numbers, and in the 67 Australian hospitals there was a steady fall from 13.6% in 2017 to 10.3% in 2020. Further analysis found that this was not due to a decrease in the absolute number of alcohol-related presentations. In fact, the number of such cases in ED increased by a non-significant 3.4% between 2017 and 2020. It was due to an increase in the average number of patients in ED from 25.7 in 2017 to 35.2 in 2020. That's a 37% increase, which was highly significant. And it's worth noting that all parts of the ED were affected. There were more patients in the short stay units, there were more patients under treatment, and there were more patients waiting to be seen. The subgroup analysis showed no difference in the pattern of the 4 studies between the recent COVID-19 states and the others. However, there was a smaller increase in occupancy between 2019 and 2020 in the recent COVID-19 states, 4% versus 22%, which was significant. Obviously, these figures rely on the clinical judgment of senior clinicians in the early hours of the morning. As such, they're not immediately auditable, and it's a single point in time prevalence study when there are many outside factors such as the weather or local events which could impact both ED occupancy and alcohol consumption. In conclusion, alcohol-related presentations have remained steady in Australian EDs, but they've reported significantly more crowding in the early morning over the last 3 years, leading to a lesser proportion of patients being there due to alcohol. There's been no such change noted in New Zealand, though this may be due to small numbers. And COVID-19 has had relatively little effect on holiday ED activity in Australasia, though the data do suggest that jurisdictions under community restrictions saw less growth in activity. Thank you, and I'll take questions.
Hi everyone, my name is Kevin Liu and I will be talking about pepper spray and tear gas exposures reported to the California Poison Control System. I have no disclosures. So a little bit of background. Chemicals such as pepper spray and mace are common tools for personal protection. We hear about people carrying it in their bags, purses. However, they are also common tools for law enforcement use for crowd control and deterrence. These chemicals have a variety of symptoms, but most are only irritative in nature, although permanent damage is possible, such as to the eyes. The recent protests in 2020 have increased attention on the use of these agents and their potential toxicity. So capsaicin is a chemical found in pepper spray and mace, and typically dissolved in propylene glycol and water, then pressurized into a spray canister. It acts on the TRPV1 receptor, a non-selective cation channel. Other activators of this receptor include acidic environments and high temperatures. When activated, it delivers a sensation of pain and heat, similar to the pungent taste of spicy food. Tear gas, on the other hand, acts on the TRPA1 receptor. There are a variety of substances that can act on this receptor besides tear gas, such as mustard, horseradish, cinnamon, wasabi. As opposed to the TRPV1 receptor in capsaicin, the TRPA1 receptor delivers a sensation of pain, cold, and itch. A little background on the history of these chemicals in law enforcement. So tear gas was developed in the 1920s and first used by the British Army in 1958 and the US military in the Vietnam War. The military use of these chemical weapons was banned by the Chemical Weapons Convention, which was ratified by the Senate in 1997. However, this did not ban its use in law enforcement. Pepper spray was developed in the 1970s and became popular for law enforcement use in the 1980s. So for the methods, all calls to the California Poison Control System between November 2015 and October 2020 that involved capsaicin substances and tear gas was reviewed. We filtered out calls that were not pepper spray, mace, tear gas related, so substances such as chili peppers, hot sauce, muscle creams were not included. We recorded the symptoms they had. We also noted whether irrigation and decontamination was done. We made sure to note whether referral to a healthcare facility was done or not, and also noted whether the incident involved law enforcement and military agents. So for this study, we had a total of 1,705 cases after we applied our inclusion and exclusion criteria. The most common exposures were to civilian self-defense sprays at 66%. There were a total of 60 reported exposures to law enforcement and military agents. Decontamination and irrigation was performed for the vast majority of calls at 93%. We did notice a trend that exposures involving law enforcement and military agents were more likely to require treatment at a healthcare facility, but this did not reach statistical significance. This chart shows that 70% of cases were treated at the site of the call, and almost 30% required further attention at a healthcare facility. This chart shows that skin irritation was the most commonly reported symptom at about 54%, with eye irritation being a close second at 51%. Respiratory symptoms were found in about 27% of cases, and GI symptoms were the least common at only 13%. But about 40% of these cases had multiple systems involved, so there was a lot of overlap. So, in conclusion, when evaluating calls to the California Poison Control System involving capsaicin-containing products and tear gas, the most commonly reported symptoms were skin irritation and ocular irritation and injury. Treatment was primarily supportive with irrigation and decontamination. Most exposures were mild and could be treated outside of healthcare facilities. And exposures to law enforcement military agents may be more likely to need treatment at a healthcare facility. Limitations to this study include a lack of long-term outcomes and potential reporting bias due to the nature of poison control center data. Further study of the long-term effects of these agents is needed to better inform potential policy changes regarding civilian and law enforcement use. That's my presentation. Thank you everyone for listening. I'll be happy to take any questions.
Well, it's a pleasure to present the reports of our study entitled Fentanyl and Fentanyl Analogues in ED patients with suspected heroin overdose in the pre-COVID era. The study was funded by the National Institutes of Health, and the authors have no commercial conflicts of interest. There were over 81,000 drug overdose deaths in the USA last year, which was the highest ever. Global drug commerce introduced synthetic opioid fentanyl analogs, which I'll term Fentalogues for the purposes of this study, into the drug supply in the pre-COVID era. Synthetic opioids now account for more deaths than heroin or prescription opioids combined. And Fentalogues can be synthesized with inexpensive precursors, leading to their growing dominance in the illicit drug supply. Examples of Fentalogues include furanol fentanyl, carfentanil, fluorofentanyl, and other synthetic opioids. Law enforcement drug seizures have confirmed that there's geographic variability, and it's expected that these Fentalogues will evolve year to year, especially as the COVID pandemic evolves. So here we describe prevalence of Fentanyl overdose in ED patients with reported heroin overdose and associations with treatment requirements. So this was an observational cohort in the pre-COVID era over 5 years. All ED patients with acute drug overdose were screened from 2 urban tertiary care hospitals, and inclusion and exclusion criteria are outlined in the table. Waste serum, if available, from specimens drawn as part of clinical care, was stored, analyzed, and confirmed toxicologically using instrumental analysis with liquid chromatography, quadrupole time-of-flight mass spectrometry. The library of drugs tested for was extensive, with over 800 drugs, including most of the novel psychoactive synthetic drugs known. Treatment requirements were defined as naloxone as well as ED disposition. So of 94 patients, there were 14 Fentalogues, 57 fentanyl patients, and 60 patients with either fentanyl or Fentalogues. There were 50 heroin positive samples, and there were only 15 with neither Fentalogues nor heroin. Of the entire cohort, only 4 patients, or 4%, had no opioid detected. So excluding methadone co-exposures in 28 patients, the mean naloxone total dose was similar between groups. Naloxone continuous infusion rates were also similar. However, it's notable that the Fentalogues in 11.1% required continuous infusion rates, compared to only 5.5% of fentanyl and 6.1% of heroin. Interestingly, repeat naloxone boluses were higher for Fentalogues, which occurred in 44.4% compared to fentanyl alone, which was in 21%. And this was statistically significant. ED disposition is illustrated in the figure. ICU admission rates were similar between groups, and hospitalization rates were higher in the heroin group compared to fentanyl and Fentalogue. So this is the first observational clinical study of empiric dosing of naloxone for Fentanyl overdose with serum confirmation. Management of acute Fentanyl toxicity involves standard resuscitative measures of oxygenation, ventilation, and administration of an opioid antagonist as the main priorities. But a greater understanding of the potency, variability, availability, and clinical consequences of Fentanyl overdose will be essential to develop better preventive and treatment strategies in the future. Post-COVID era studies are now ongoing with the current group. So in conclusion, Most ED patients with suspected heroin overdose had confirmed fentanyl or fentanyl overdose. Naloxone repeat boluses were required more frequently for fentanylogs compared to fentanyl, and ICU admission rates for fentanyl and fentanyl overdose were similar to those of heroin. I'd like to say a big thank you to our friends at NMS Labs, the Frederick Reeder's Family Foundation, as well as ACMT, who are the co-investigators for the study, and also a special thanks to the Mount Sinai Emergency Medicine Research Division. And thank you for your attention.
Hi everyone, my name is Alexandria Cronin, and I'm a research scientist for the Department of Emergency Medicine at the University of California, San Diego. Today I'll be talking to you about a project entitled Trends in Marijuana Screening and Testing Before and After Recreational Use Approval. My co-authors are listed on the screen, and the authors have no conflicts of interest to disclose. So some brief background on this project. The recreational use of marijuana was legalized in California officially in December 2016, along with several other states that you can see listed in the map. The impact of this approval on emergency department testing and screening has not been thoroughly explored since this approval. Thus, the goal of our project was to assess whether marijuana screening and testing changed in any way due to the legalization of the recreational use of marijuana. We also accounted for the time between when marijuana use was first approved in 2016 and when some of the first stores opened at the beginning of 2018. This ultimately was a retrospective multi-center study, including 2 emergency departments that are part of an academic medical system with a combined annual census of roughly 80,000. The first hospital is an urban level 1 trauma center, and the second hospital is a suburban academic hospital. We looked at data that were from 2016 through 2019, and we included all adult patients that were 18 years of age or older that had an ED visit. Ultimately, we compared the rates of marijuana screens and tests per 100 ED visits annually. So some initial results here. So annual ED visits increased from 78,000 visits annually in 2016 to 85,000 visits in 2019, which was roughly an 8.1% increase. The overall rate of positive marijuana screens, so not broken down by any other subgroup, per 100 ED visits increased by 16.5%, which is almost a fifth. And the overall rate of positive marijuana tests per 100 ED visits increased by 11.9%, again, not stratified by any kind of demographic group. However, when stratified by demographic group, the positive marijuana screen rates and test rates are kind of interesting to look at. So as you can see, in general, all age groups had an increase. And some of the most notable increases are for like the 75 plus age group that did have an increase between 2016 and 2017, which stayed pretty consistent through 2019. We also saw some increases, for the 18 to 39 age group, the 40 to 59 age group, et cetera. And then for the positive test rates, as you can see, again, they all increased pretty much, except maybe that 40 to 59 age group, there was some fluctuation. So there was an increase in the middle, but maybe ultimately kind of stayed the same. And that's kind of similar for the other age groups, though there were overall kind of increases. For positive marijuana screens and rates by sex, so we looked at how things were distributed by males and females. You can see here that ultimately both positive marijuana screens and rates went up for both groups. And there were ultimately more males than females with positive marijuana screen rates and tests. Limitations and conclusions. So this was a retrospective chart review, not including recent trends from 2020 and 2021. Since the legalization of marijuana for recreational use, there have been some changes, as you've seen, but maybe no specific trends. So it would be important to look at kind of the more long-term effects of this approval. And we saw some trends kind of within different demographic groups, but further analyses could incorporate other socio-demographic breakdowns like race or ethnicity, income level, education level, or even potentially clinical characteristics like chief complaints or diagnoses. Again, my name is Alexandria Cronin. I'm a research scientist for the Department of Emergency Medicine at the University of California, San Diego. And my email address is aocronin@health.ucsd.edu if I can answer any questions. Thanks for listening.
Good afternoon, everyone. My name is Christine Ramzan. I'm a research associate with the Department of Emergency Medicine at Rutgers, New Jersey Medical School. Today, I'll be presenting to you my project titled Trends in DUA Visits, abbreviated for Drug Use Adverse Effect Visits, at an urban emergency department during New Jersey's first wave of coronavirus. I was assisted by 3 faculty members in my department, which include Aaron Nucky, Anthony Rosamia, as well as Dr. Lewis Nelson. Okay, none of the authors have any disclosures. Okay, emerging reports show that there was an increase in drug use related events and deaths and visits to the ED during the COVID-19 pandemic. This has been verified by sources such as CDC and as well as SAMHSA. Recent studies looking at ED visits during COVID-19 focus on specific complications such as overdose and do not look at DUAEs overall, which I will define in the next slide. Specifically pre, during, and post COVID's first wave. There has been a recent study published in JAMA Psychiatry, but that study focused on overdoses. Similar to that study, what we also did was we reported a granular level of trend and rate analysis for all DUAEs pre, during, and post COVID, and we compared that to trends in ED volume during that same time frame. So DUAEs we defined as all patient encounters that relate to poisoning by or adverse effects of drugs, medicaments, and biological substances, as well as mental and behavioral disorders due to psychoactive substance abuse. This was a single center retrospective study of all DUAE visits, drug use adverse effect visits within the timeframes February to May of 19, comparing to February to May of 2020. We chose this specific time period as it encompassed the first wave of COVID, as well as gave us some time before that first wave and after COVID, after that first wave, so we can look at the relationships of the trends of what happened over time. We normalized the DUAE data to ED volume. All data were reported using proportions and confidence intervals, and we analyzed them and compared rates using the chi-square difference of proportions test. So prior to the first wave, the volume of all ED visits relating to DUAs surpassed the rate for 2019 every single week, meaning that in 2020, prior to COVID-19, we actually had more DUA visits than 2019, as much as 123.8% of 2019's visits. I have the breakdown here in table 1, week by week from week 5 to 25, which approximately is the end of January to the end of May, and how DUA visits volume changed. However, we found, as you can see on week 15, during the first wave of coronavirus, the rate of DUA dropped to as low as 52% of 2019's volume, meaning we saw essentially half as many DUA visits during the first wave compared to 2019 during that same time frame. Similarly, ED volume, as we all know, across the country fell during the first wave, as low as 62.8% in our case of 2019's volume. But even after the first wave of the pandemic, ED volume never returned to its baseline in 2019. We only recovered to 70.4%, as you can see in the graph on the blue line. In contrast, DUAE volume right after the first wave, it spiked up and it surpassed that of 2019 volumes. It went to 1.2%, as close as 1.6%. That approximately 1.6 times of 2019's volume, approximately 145% up until April. So to put these in terms of rates, prior to the first wave in 2019, we had 9.6% of DUAEs in the corresponding time frame. In 2020, prior to the first wave, we had 10.4% of visits related to DUAs. We found that there was a drop to 8.3%. That was a drop also as well as from 2019, which during that time frame, 9% of visits were DUAs. After the first wave, however, in 2019, only 9.9% of all visits were related to DUAs. We went to 12.1% of all visits related to DUAs in 2020. All these changes were statistically significant. So overall, during the first wave, as we can see, there was a reduction of ED utilization for all patients, including those with DUAEs. While in contrast to ED volume, which lagged in its return and it never came back to baseline volume within the time period analyzed, we found that DUAPE recovered to baseline and surpassed 2019 DUAE values much more quickly. So the sudden rise in visits post the first wave could be attributed to several things. It could be attributed to increased drug use, changes in EMS practice, decrease in access to addiction support and mental health services, as well as patients may have had a sense of safety due to reduction of statewide COVID cases. Future studies should look at determining the causes for the changes in ED utilization for DUA during COVID, how to address them, and specific trends for type of complications. Thank you.
Hi, everyone. I'm Dr. Eric Lavonis from Denver Health and Rocky Mountain Poison and Drug Safety. I'm happy to present some of our work around antivenom treatment of snakebite. The research I'm presenting today was funded by a grant from BTG Specialty Pharmaceuticals, which makes one of the antivenoms we studied. Our team had full access to the data and complete control over study design and execution, including the decision to present. The North American Snakebite Registry is also supported by a grant from BTG and managed independently by the American College of Medical Toxicology. About 5,000 people are treated in U.S. emergency departments for rattlesnake bite each year, the vast majority of whom are treated with antivenom. There are currently 2 antivenoms available in the U.S., a Fab antivenom made in sheep and a Fab 2 antivenom made in horses. All antivenoms are dosed to clinical effect, but real-world data about how much antivenom patients require are surprisingly lacking. Our data come from the North American Snakebite Registry, which is a sub-registry of the ACMT's Toxicology Investigators Consortium. In 2019, 17 treatment sites reported a total of 176 snakebite cases to the NASBR. All patients in the database were managed at bedside by medical toxicologists. Data were collected prospectively into this purpose-built registry. So once again, our research question is how much antivenom do rattlesnake bite patients actually require or receive in clinical practice? This is a prospective observational study of all rattlesnake victims entered into the NASBR in 2019. We used descriptive statistics. Out of 174 rattlesnake bite patients in the registry, 114 were treated with antivenom. 53 patients received only ovine Fab, and 27 patients received only equine Fab 2. The other 34 patients received both antivenoms. We excluded these subjects because they differ in many important ways from patients managed with only one antivenom. As you'd expect, the data had significant skew, so we used non-parametric statistics. The median total dose of Fab antivenom used to treat one rattlesnake bite patient was 10 vials. This includes antivenom used to gain initial control of the signs of envenomation, routine administration of antivenom to prevent recurrent venom effects, and any additional doses used to treat recurrent venom effects. Overall, about 80% of patients received more than one dose of Fab antivenom, with a median interval between dosing events of about 6 hours. Among patients with equine Fab 2, the median total antivenom dose was 15 vials, and 63% of these patients received more than one dose. The median interval between doses was 5 hours. Here's a graphical representation of the dosing. On the left side, the solid symbols are antivenom doses that were reported to be given as maintenance therapy to prevent recurrence, while the open symbols on both graphs are a mixture of antivenom doses given to achieve initial control, doses to treat recurrent venom effects, and those with no reason specified. As you can see, one patient in each group received some antivenom more than a week after envenomation, presumably for late venom effects, which we know happens with all antivenoms. If you look more closely at the first 48 hours after envenomation, you'll see that patients in both groups tend to have multiple dosing events in the first 24 hours. This shows the treatment of rattlesnake envenomation is a dynamic process for which retreatment with antivenom is often necessary. Putting on my P&T chair hat, it's helpful for a hospital which treats snakebite patients frequently to know the mean antivenom utilization rather than the median. On average, a rattlesnake bite patient consumes 11.4 vials of Fab or 17 vials of Fab 2 for the entire course of therapy. Understanding this ratio of 0.67 can help a pharmacy director determine antivenom stocking levels and make cost comparisons. Now, this study has all the limitations of an observational study. In addition, in the 2019 version of the NASBR, it was not always possible to tell the reason a specific dose of antivenom was given. Although all patients were treated hands-on by medical toxicologists, snake venom and treatment practices vary between sites, making direct comparisons difficult. That said, we can state with confidence that most victims of rattlesnake envenomation require multiple doses of antivenom during their treatment. The median total dose administered is 10 vials of bovine fab or 15 vials of Fab 2. I'd really like to thank the NASBR investigators, also the ACMT for developing and overseeing the registry, my colleagues at Denver Health and Rocky Mountain Poison and Drug Safety, and the folks at BTG who enable us to do research with a high degree of independence. Thanks very much.
Hello, good day. Welcome to my presentation. My name is Dr. Henry Montilla. I am one of the emergency medicine residents at the University of California, San Diego. Thank you for taking the time to come to my talk. Today, I'll be talking to you about amphetamine abuse in emergency department patients with suicidal ideation. As you may know, this is a rather ubiquitous issue here in Southern California, and it's a topic that I do find rather interesting. At this time, neither me nor my co-authors have any conflicts of interest to disclose. Getting to the topic in hand, amphetamines are a well-known stimulant with very high potential for abuse and addiction. Many chronic users develop a myriad of psychotic symptoms, including but not limited to paranoia, hallucinations, and delusions. Many of the patients that we see in the emergency department who are actively intoxicated with methamphetamines also happen to have suicidal ideation. In many emergency departments across the country, using the urine drug screen test for medical clearance has become standard of care. However, there is a paucity of data when it comes to the prevalence of positive amphetamine screens in patients with suicidal ideation and its relationship to the final patient disposition. Our study was a retrospective study of adult patients seen at our two university emergency departments, one being an urban level 1 trauma center and another being a suburban academic hospital with combined annual census of approximately 80,000 patients. We were looking at patients who had a urine drug screen performed between May 1st, 2015 and April 30th, 2020. We had a rather large patient sample. A total of 388,931 patients were seen between our two EDs. Of those patients, 19,347 were flagged by our system for suicide. Of the patients who were flagged for suicide, 11,888 had a urine drug screen performed. Of the patients who were flagged for suicide, 44.8% of those had a negative screen, while 16.7% of the patients who flagged for suicide had a positive initial screen requiring further confirmation for amphetamines. Out of all the patients seen in our emergency department, a total of 1.9% or 7,361 patients had a positive initial screen requiring further confirmation. Of the patients who were flagged for suicide risk, 72.9% had a negative screen and 27.1% had a positive screen for amphetamines and were pending confirmation. Of the patients who were flagged for suicide and had a positive initial screen and were pending confirmation, 19.6% were admitted, 73% were discharged, and 7.4% had an other disposition, which included against medical advice, eloped, left without being seen, transferred, or undetermined. When compared to the patients who were flagged for suicide but had negative amphetamine screen, in this group, it was seen that 29.6% of those patients were admitted, 59.2% of those patients were discharged, and 11.2% were deemed as other. Using chi-square, it was determined that there is a statistically significant difference between discharge rate in patients who were flagged for suicide who screened positive and those who screened negative for amphetamines. This difference was not seen in patients who did not screen positive for suicide. The discharge and admission rate was not statistically different in this group. From our data, we were able to conclude that the prevalence of amphetamine-positive urine drug screen was high in the population that we studied. A total of 1.9% of all the patients screened had screened positive for amphetamine. And in the patients that were flagged for suicide, 16.7% of these patients screened positive for amphetamine. There appears to be a significant difference in the rate of admission and discharge on patients who are suicidal, who screen positive for amphetamine, and those who do not. Patients who were flagged for suicide and screened positive for amphetamine were more frequently discharged from the emergency department compared to suicidal patients who screened negative for amphetamine. We theorized that the patients who had a positive screen for amphetamines and were flagged for suicide were more likely to have resolution of their symptoms as their intoxication improved. We also theorized that the patients who flagged for suicide who had positive screens were likely deemed to have stimulant use disorder compared to the patients who did not have amphetamine positive screen and were more likely to have true underlying psychiatric diagnosis. Part of the limitations of our study include the fact that the legal status of these patients was not specified. Whether they were on a psychiatric hold or not, it is unknown. Therefore, it is unknown to us whether an emergency medicine physician or a psychiatrist actually cleared these patients. It is challenging to determine which of these patients are actively suicidal while intoxicated with amphetamines versus the patients who were using suicide ideation for a means of secondary gain. We understand that the urine drug screen is not a perfect test, but can be used as a helpful tool to stratify these patients. Further studies could look into the length of stay of these patients and see if there's any difference in patients who screen positive for amphetamine versus those who do not and also have suicide risk. I want to take a moment to thank my co-authors, Dr. Clark, Dr. Castillo, and Dr. Srihari. And I also wanted to thank you for taking the time to come to my presentation.
Hello, everyone, and thank you for joining me for our presentation on trends in pediatric emergency room visits during the first real full month of the COVID-19 pandemic. My name is Zev Garman, and I'm a newly minted fourth-year medical student working with the Department of Emergency Medicine at the University of Virginia. We have no relevant financial disclosures or conflicts of interest. To set some background, on March 30th, 2020, our Virginia governor issued an executive stay-at-home order asking all people to stay in their places of residence except for necessary trips, including obtaining food, seeking medical attention, and other things. Around the same time, anecdotal reports and news articles started to come out about a drop in patient census in emergency rooms across the nation, and later reports would show an average of 42% drop in patient census. We wanted to examine trends in our own emergency room. The graph on the left are just raw patient visit data. The purple line on the bottom is 2020, and the other three lines are the previous 3 years. So even just eyeballing it, we can see that there's a drastic decrease in daily emergency room visits. We chose to focus specifically, at least initially, on pediatric visits because there were many UVA medical students who would have fit into the older range, who historically went away for a week for spring break in this period, but were asked to stay home after their spring break due to the pandemic. So this could have introduced a false drop in numbers had we examined that age range. Our question is whether there was an increase in sort of the severity and complexity of patient visits if people were only seeking medical attention when absolutely necessary. In other words, were there more seriously ill patients? Do they require more resources? Were their encounters overall more complex? To get at this, we pulled data from the day after that executive order through the next 30 days, and we compared those data to data from the same dates in the previous 3 years. We compared them year by year, in other words, 2020 to 2017, 2020 to 2018, and so on. And then we also we averaged those 3 previous years and compared that historical average to our 2020 data. The first thing we looked at was visit acuity, and that was assigned at triage, 1 being most emergent and 5 being not at all urgent. We had to exclude 1s and 5s because there just weren't enough data points for meaningful analysis. What we found was that the proportion of daily emergent or level 2 visits rose by an absolute 5.3% above baseline, despite an overall reduction in average daily emergent visits of 4.9 patients. We did not see any significant difference in proportion of urgent or less urgent, so levels 3 and 4 visits, despite overall decrease in daily visits. The next thing we looked at was a surrogate of resource utilization and severity of presentation in admissions. And again, we saw a overall increase of 6.9% in admissions per day. However, that followed with a 2.7 patient overall reduction in total number of admissions. We also wanted to examine resource utilization in the form of medications administered per patient and orders entered per patient. Those would be surrogates of complexity and need for patient visit, but neither actually demonstrated a significant difference between 2020 and previous years. So, putting that all together, we see that there was about the same decrease in overall patient census in our emergency room as was reported for emergency rooms across the country. We did find that there was a greater overall proportion of emergent, so level 2 acuity visits and subsequent admissions, although the proportion of less urgent visits didn't really decrease. So this really tells us that many people stayed at home and slightly sicker people presented, but there wasn't as much of an expected decrease in less urgent visits. Interestingly, we found that the resource utilization in terms of medications and orders wasn't really changed overall. So this suggests that despite slightly more sick people proportionally seeking attention, their visit complexity was unchanged, and the demands on healthcare providers would have been unchanged per visit. Some areas for further inquiry would be if there were any more common chief concerns in 2020 for presentations than in previous years. So what things were really bringing people in specifically that was different from historical data. I think it would also be interesting to get at what factors beyond maybe medical factors weighed into patients and their parents' decisions to seek care, although admittedly it would be hard to extract these data from presentations in previous years. And then the last thing we could do would certainly be to examine trends in adult emergency room presentations after excluding the common age ranges from the UVA graduate and undergraduate populations. That's the end of the presentation. Are there any questions?